Ma'am, we are live. So, with all your due permission, we are beginning with the session for today. Good afternoon, everyone. This is Batul, the moderator for today's session, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our stalwart who is present here with us today. Well, she needs no introduction at our platform, but yet it's our pleasure and honor to introduce her. She is none other than the very renowned gynecologist, Dr. Tripura Sundari ma'am. Ma'am is MBBS, MD, DGO, FIMS, consultant and HOD at Obstetrics and Gynecology at Keams Hospital, Secunderabad. With ma'am's wonderful insights, we are going to talk about the topic for today, which is evaluation of post-menopausal bleeding. So now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her for her precious talk to begin. Ma'am, over to you.
Thank you. Good afternoon, everybody. Today, I thought we were talking about all the obstetric topics. We'll go for a other end of the life, that is the postmenopausal period. And when there's a bleeding, everybody is scared what to do, whether there's a malignancy. So we'll just discuss how to evaluate a patient who's having postmenopausal bleeding. Let's go. So, welcome. Greetings from the hospital where I'm working at Keams Hospital. And welcome to our place, the vibrant Hyderabad, from where I am. And I welcome you to our place. And you all know menopause is the permanent cessation of normal menstruation for more than 1 year. And it usually occurs around 40 to 45, 55 years. If it stops less than 40 years, you all know we call it as premature menopause. And postpartum bleeding from genital tract after menopause is one thing which is very alarming. And the commonest symptom are carcinoma of the uterine cavity, either carcinoma cervix or carcinoma body. Everyone with postpartum bleeding should be critically evaluated, rule out carcinoma. Unless it is proved it's not carcinoma, neither you should relax nor the patient should relax. So patient is definitely worried because they get so many informations. But still, in spite of we telling so many times, patients do neglect and say this is common. When the patient is about to stop a periods, they come to us very late with the result that patient is already in a very late stage of malignancy where we cannot help her much. So the concern is uterine bleeding after permanent cessation of menstruation is called postmenopausal bleeding, and it is caused by endometrial hyperplasia. And it can be a cause of carcinoma, endometrium, or cervix unless otherwise proved. 90% of women with endometrial carcinoma present with vaginal bleeding, and endometrial cancer is the most commonly diagnosed reproductive tract malignancy. It is the fourth most common cancer among women, breast, lung, and colorectal preceding it. Postmenopausal bleeding is most common symptom, and it can be spontaneous, related to HRT, or use of subs. So you have to take a detailed history, know what is her preceding treatment which she received, whether she's a case of carcinoma breast. Recently, we had a patient who is a case of carcinoma breast operated. She was in tamoxifen. She came to us bleeding, scan showing very thickened endometrium. So we are bothered whether it is malignancy or effect of tamoxifen. So we had to evaluate because we all know that this Lynch syndrome is there. All three organs, that is uterus, your breast and the colon can be involved. So we have to evaluate the patient. So you all know the commonest cause of postpartum bleeding is hormone replacement therapy. Patient takes hormones regularly and she starts bleeding. Atrophic vaginitis is one thing. When the estrogen levels are very low, she may bleed. Cervical polyps, endometrial atrophy, endometrial hyperplasia, and lastly, endometrial cancer. To reach that stage that it's not endometrial cancer, you have to evaluate all these things and rule out all the other causes. So as I told you, it can be local, that is cervical cancer, cervicitis, polyps, trauma. Coming to uterus, it can be hyperplasia, again polyps, endometritis, endometrium, leafy loop, or it can even be tuberculosis of the endometrium. Coming to tubes and ovaries, it can be carcinoma of either tube or the ovary, it can be primary or metastatic. When you think of urethra, caruncle is a more commonly seen in postmenopausal women. It can be a case of carcinoma bladder, again tuberculosis of the bladder, or trauma is another thing which is very least expected. And vulva, it can be carcinoma vulva, dystrophies, and again kava. Coming to systemic causes, It can be bleeding disorders, patient on anticoagulants, HRT, is in reproducing tumors. This anticoagulants, one thing which we should very carefully take history, because most of them they may not be realizing that they are taking anticoagulants, especially when they had some heart valves being replaced. So when the levels are not properly maintained, she may have bleeding. And as we all know, what is the palm coin classification? It can be polyp adenomyosis, leiomyoma, malignancy, like this structural causes, or it can be coagulopathy, ovulate dysfunction, endometrial, iatrogenic, or not yet classified. So this is thing you have to take history and see into which condition this falls. And again, leiomyomata can be submucosal, otherwise submucosal leiomyomata causes bleeding. It is subserous or myometrial, fibroids may cause pain, but usually don't cause bleeding. So when you come to etiology of this thing, if you revise again, endometrial atrophy is main cause 75%, because once you put a scope, you can see endometrium is all thin, there is nothing is there. Even the vagina and the vulva, vagina and the cervix also look very thin and well, maybe spots, that is, hemorrhagic spots may be there. Typical, so most of the causes can be endometrial atrophy. Endometrial hyperplasia is seen, polyps. Endometrial cancer is only in 10% of patients who are having postmenopausal bleeding. And estrogen withdrawal, patient may be taking some drugs for HRT. Usually they stop it without informing the doctor, and these are realizing that patient can have bleeding. So postmenopausal bleeding is considered to be the cause of endometrial neoplasia until proven otherwise. So it is very important for you to evaluate. See, if that cancer is not the cause, then you can always assure the patient and go for the other treatments. 90% of women with endometrial carcinoma present with only vaginal bleeding. So coagulation disorder, as I told you, endometritis, trauma to the pelvis, thyroid disorders, hormone medication, tamoxifen as side effect, HRT as I told you, when you take for 5 to 6 months, patient suddenly stops, she'll have bleeding. It may be mistaken for bleeding per rectum, hematuria, local injuries with postcoital trauma, which patient may not come out with the history because she may feel shy or she may not be able to come out with that. So it is very important for you to take history, take the patient to confidence, and slowly ask, she may come out with the history. Because I had one patient who was mentally not sound. She came with postmenopausal bleeding. So when we tried to evaluate, she was having foul smell and discharge. And when we examined the patient under anesthesia, we found foreign body. That is, she is denying, but she has put the tubeless pieces into her vagina. They are around 75-year-old lady. We had to put it under anesthesia. So this is all very rare, but very important thing. So unless you take history properly, examine her properly, it may be missed. So as you see, of all the things, endometrial hyperplasia is one thing, and in that again, carcinoma is the main thing we had to rule out. 50% cases only atrophy. And endometrial histopathology, if you take the postmenopausal patients, endometritis is a common thing, and endometrial adenocarcinoma has to be ruled out. So carcinoma endometrium, if you take, peak age is around 60 to 64 years. PMB is not on HRT, the incidence is 4.9 to 11%. PMB, that is postpartum bleeding, 10 or more years following menopause, is a higher risk. Postpartum bleeding was 60 years of age, 13% risk of carcinoma endometrium. So whichever you take, the patient with postmenopausal bleeding comes to you with, when patient more than 60 comes to you with postmenopausal bleeding, it becomes our mandatory that evaluate her and rule out carcinoma endometrium. Or of course, carcinoma surgery can make out with a simple speculum examination. Risk was lower for those in younger and older age groups, and incidence in women having HRT is only 0.505%. Women receiving tamoxifen, again, the risk is about 10%. So tamoxifen as such causes endometrial thickening, but you can't relax like that. We had to take a biopsy. Approximately 90% women with endometrial carcinoma present postmenopausal bleeding, and although postmenopausal bleeding most commonly due to other conditions, as I told you, it is very important to exclude carcinoma. So these are all the common conditions where it can cause bleeding and pain, and endometriosis in the postmenopausal period is also not rare. So if the patient comes with pain, we have to also you think about carcinoma, not only carcinoma, but also endometriosis. So, as again say, history is very important. Again, like menarche, menopause, LMP, bleeding history in detail. Is any postcoital problem? Look for risk factors like our relatives having similar problems, multigravida, obesity, diabetes, carcinoma drug, carcinoma breast, and whether she's already in HRT or taking any anticoagulants. Family history of malignancy is important, and you should take whether she had any previous biopsies. She could have had a endometrial hyperplasia, say, some 5-6 years back. When she was having biopsy, it could have been hyperplasia without atypia, but there is a chance that it could be with atypia now. So the having previous history and any organism of the previous biopsies is very important. So history taking, like age of menopause, habit of smoking, duration, type of bleeding, previous pap smears, if any, you all know, pap smear can detect a carcinoma cervix, which can be detected nearly 10 years earlier. So this is very important for you to take an opportunistic pap smear for any patient coming to you for any other gynecological conditions. And an injury, postcoital bleeding, drugs and use of HRT and marina. So many times I've seen patients who had forgotten copper T in the uterus. They come to with bleeding. They do not even probably know that copper T is there, or they've totally forgotten. When you do a scan, you can see an intrauterine device, and that itself could be a cause because chronic irritation, more than 10 years, 15 years. When you take out the patient and take a biopsy, she will be totally relieved. So, a speculum examination, bimanual examination to know the size and any deformity, and rectal examination, especially when you see a mass in the cervix that is spreading to the rectum, and a pap smear, people a biopsy, histoscopic guided biopsy is a gold standard, of course, you all know, and a scan, MRI, and the last thing would be to do a THBSO. When you are doing a radical hysterectomy for these cases, if you don't have facility, if you're doing simple TH, it is always important that you send it for a frozen biopsy to know if there is any malignant part in that. If that is the thing, then and there you can call for an oncologist, getting a radical hysterectomy. That is the lymph node dissection also can be done, and patient may have to go for radiotherapy. So, for evaluation of postpartum bleeding, apart from history, speculum examination, transvaginal scan, stethoscope guided biopsy, spontaneous postpartum bleeding is there. You do thickness of endometrial echo complex. Either EEC is very important. And in that, EEC is more than 4. Evaluation with endometrial sampling is very important. Persistent postmenopausal bleeding, an office histoscope, and or a contrast sonography may be seen. With that, we can make out there is a polyp. But histoscope is gold standard. We can visualize at the same time, we can take out the polyp also. So this is the one you can see there. The growth is there. And in that, if you see, if you flow chart, you see acute pathway. If you know bleeding reserves are there, you can see whether there is expect management or should do an active management. This I was telling about liquid-based cytology. This should be a routine in places where there is no facility for that. A simple visualization of the cervix with a cusco speculum can give volumes of information whether the cervix is healthy, is any lesion is there, any polyp is there. 50% cases can easily be detected, and even normal pap smear itself can make out things. Of course, if you have facility, a liquid-based cytology, at the same time, even if you virology, you know the thing, whether the patient is having any disease almost 10 to 15 years before. And in these patients, now you all are talking about the immunization of the patient. That is, like all vaccines, you have got vaccine of the cervical cancer, and that gives almost 80% coverage, and especially when it is given between 10 to 14 years, even single dose is helpful, but 2 doses at 2 months apart will cover the patient, and especially before she is married. So that's very important. So please encourage all these patients, young girls, and of course, we are now saying even boys, they get the immunization done so that the not only cervical cancer, the vulvar cancer also can be treated, and even boys, the penile cancers also can be prevented. So post-viral bleeding, if tamoxifen is there, you have to again stop assessing, take a biopsy, rule out. Just don't think that because of tamoxifen she is having hyperplasia. They always do a biopsy and rule it out. So this is the endometrial complex. This should be less than 3. If it is more than that, but I say the patient is having postmenopausal bleeding, whatever is the endometrial thickness, please take a biopsy. The patient is asymptomatic, no postmenopausal bleeding. Now many papers say you can wait up to 11 millimeters, even though there is no bleeding, you can wait. But easily cut off, we are all scared. Tomorrow something happens, nobody will be able to give an answer. So if endometrial biopsy should be done, if there is no postmenopausal bleeding, we can wait up to 8 to 10. But if there is postmenopausal bleeding, even if it is 2 or 3 also, you have to do a biopsy. It could be probably only due to atrophic endometrium, but you have to do a scopy and see what is the cause. This highly vascular endometrium, you can see, this is the one where you have to take a scope and take a biopsy. This is the comprehensive endometrial thickness where you can evaluate. And usually you can see collection of endometrium, this fluid is there. This can be best taken for a thickened endometrium. And coming to atrophic vaginitis, I told you 60 to 80% is the incidence. Estrogen therapy, 15-25%, which is definitely it will help. Polyps will be there in 2 to 12%. Endometrial hyperplasia is seen in 5 to 10%, and endometrial carcinoma is only 10%. So coming to atrophic vaginitis, postmenopausal for more than 10 years. Treatment of atrophic vaginitis is topical or systemic estrogens. We have got now Evalon gel, which can be used, but if it is having local use, is always better to give a local listing. But systemic giving estrogen may not be necessary or may not be needed when you have a local problem, because this will definitely overcome the liver and passage, and patient is safe for the thing. So it can be given even for patients who had a history or they are more prone for breast problems. So curettage has also been known to be curative for atrophic endometrium, but always you should give them histopathology and then give them the proper estrogen, because atrophic vaginitis is due to low estrogens. So this is the picture you get when you put a speculum. You can see all that speculum, spottings on the vaginal wall. It is typical of that. And usually within a month or two, patient will definitely have relief and she can continue it for 6 to 8 months. Polyps, endometrial polyps are more common. And endometrial hyperplasia is the result of unopposed estrogen. So an abnormal proliferation of endometrial stroma and glands and represents a spectrum of endometrial changes that range from glandular atypia to frank neoplasia. So taking a biopsy is again very important. These polyps can be cervical, which can be seen when you put a speculum. We can just twist it and take out. If it is intrauterine, you have to put a hysteroscopy and remove it either with a stone horn for if you have a removal for the instrument, you can easily take out. This is a cervical polyp, you see. This is hysteroscopic removal of the polyp. And this is the how it looks, a simple polyp. And if it is a malignant one, you can see it's really vascular. And when you touch, it bleeds. The very picture itself, we can make out it can be a case of malignancy. These are all the different types of, these are normal endometrium. This is the fibroid polyp you are seeing. This is a small, simple polyp. And you can see the endometrial, septa also you can see in the hysteroscopic picture. Foreign bud can be IUCD, a Lippis loop. So when you do hysteroscopy, you can remove the copper T or marina, and a simple DNC will always help. Endometrial hyperplasia, abnormal proliferation 5 to 10% in postmenopausal bleeding, excessive estrogen stimulation, more than 3 millimeters postmenopausal or more than 5 millimeters HRT is again significant. Management without atypia, you can give progesterone, oral injectable, or put a local marina. If with atypia, it's pre-malignant, better you go with a hysterectomy or and followed by chemoradiation if necessary. Hysterectomy can be an open abdominal hysterectomy, or you can do lap hysterectomy. But if it is a case of carcinoma, it is always better you go for a open. There's always a controversy and there is a debate going on. but it's better, they say, the oncologists also prefer to do an open hysterectomy with bilateral lymphadenectomy, because the remnant surgery, remnant carcinomatous tissue is more in lab compared to open. So again, it is debatable. They say if you are very good at doing lab, you can go ahead with it. But most of the lab surgeons are not very good. So it's always better you have to assess yourself and go for a thing. Better is to go for a open hysterectomy with bilateral adhesive lymphadenectomy. And now it is carcinoma endometrium that even do omentectomy and parietic lymph nodes. So this is a normal endometrium. This is endometrial hyperplasia. And carcinoma endometrium, as I told you, second most common gynecological malignancy is estrogen dependent. 10% of postmenopausal, 90% with bleeding. Now we are seeing actually more case of carcinoma endometrium. So it is imperative and it's very important for you to take a biopsy in all perimenopausal patients with abnormal bleeding and see whether it is ATPR is there or not, and go ahead with a treatment, because just relaxing that is only postmenopausal. Usually that's what happens. Patients don't come to the thing. It is at 40, 45, 50. It is a time when you go to see your period. I mean, periods are going to stop. There's no need to go to a doctor, because usually be like that. That is how they are neglected and they come to us very late. So 90% of them present with bleeding. So it is confined to the body, or it may extend to the cervix, or to go to outside into the pelvis also, or very distant metastasis. We don't want the patient to come to us in this stage. We want her to be in carcinoma endometrium also. To actually go in detail, many types of endometrial malignancies, and how they behave, how they differ in treatment is again a big subject of itself. So it is very important for you to send it for histopathology. And even the doubt is there in a smaller place, if you are doing, you can always send it for a frozen biopsy, know the type of endometrium, because initially it was saying it was carcinoma endometrium, simple hysterectomy, that is sufficient. Now it has already changed. So when you're doing even a case of carcinoma endometrium, when it's the first stage also, it should know the type of the histological pathology and then manage the treatment. So as I told you, 1/3 of endometrium proceeds hyperplasia, and endometrial carcinoma is most common gynecological malignancy. Fourth most frequent site of malignancy in females. Risk factors include obesity, anabolic estrogens, polycystic ovarian syndrome previously, and nulliparity. But this is not so in all the cases, which is what we were reading initially, but we are seeing in carcinoma cervix in patients who had only 1 or 2 children. We are seeing endometrial carcinoma in patients who are having 5 to 6 children. So all cases are not same. Every case has to be individualized. The common presenting symptom, as I told you, is postmenopausal bleeding. Though a majority of patients will be postmenopausal, 20% patients will be premenopausal. So perimenopause is the time when you get a carcinoma endometrium. Again, early gravida, obesity, scan and MRI will tell the staging. Radical hysterectomy is the treatment of choice. Chemoradiation depends upon the type of the histopathology. But one thing nice compared to carcinoma cervix is the carcinoma endometrium prognosis is good. The age, hormone replacement therapy, and endometrial cancer, tamoxifen when she's taking, she has more 3 to 6 times increase chance of having endometrial carcinoma. Both the dose of drug and duration therapy is there. Treatment more than 5 years with both grade and stage of tumor may be higher. Relation to hereditary non-polyposis chronic cancer like Lynch syndrome, as I told you, is autosomal dominant. Other risk factors in cancer are obesity, hypertension, hyperesteronism. It can be endometrioid, serous or clear cell origin, which is very less, but endometrioid is more common. And diagnosis, as I told you, history, TVS, sonohysterogram. Again, this is controversial. When you do here sonohysterogram, you're pushing fluid into the uterine cavity and it is going into the peritoneum. So, is there a risk of spreading the cells into the peritoneal cavity? It's again a debatable. Some people say nothing is there, but I'm scared. I don't like to do it because there is definitely some amount of cells may spill into the peritoneal cavity. You may be spreading the disease. So definite diagnosis by histology, by hysteroscopy. DNC, a blind technique, covers over 60% of cavity. People have biopsy, a chance of missing tissue are there. So gold standard is doing histoscopic DNC. So take-home message is postmenopausal bleeding occurring in menopause. Not all cases are malignant, but it's very important for you to confirm that it is not a malignancy unless proved otherwise. So commonest cause of is atrophic endometrium and simple polyps. Most of the time, we put a scope, we see a polyp, we take out, patient is relieved. So you can avoid unnecessary hysterectomies and attention to the patient and anxiety to the family. Though evaluation needed to rule out carcinoma endometrium, high-resolution TV scan of uterine pathology is very important. Cutoff is 4 millimeters. Endometrium is symptomatic, but I tell you, even it is 2 millimeters, better you do a biopsy because all stone scans are not same, and you need a very good resolution of scan machine to know the correct thickness, and that's not available everywhere. So when there is a complaint of postmenopausal bleeding, better you do a biopsy and know the histopathology. Histoscopic evaluation is gold standard and treat as per the diagnosis, whether polyp or atrophic endometrium, or there is only hyperplasia, or there is a malignancy. Early diagnosis, management of carcinoma endometrium or carcinoma cervix will definitely increase survival chances are very high. Thank you. And I think each case has been individualized and you have to treat as per the patient's choice, availability of evidence, availability of investigations, and how the patient can afford all this treatment or not. So accordingly, doing a biopsy and going for this thing may be academically correct. If the patient is not able to afford, you can do as well a hysterectomy and get it for a frozen section and decide in case where there is patient affordability is less and the patient cannot come again and again for the investigations. Thank you.
Thank you so much, ma'am. Thank you for your enlightenment talk that you have shared on our platform on such an important topic. Thank you so much for making us understand about the topic in such a better manner. We have received few questions from the participants. So with all your due permission, I would like to put across those questions to you.
Sure.
So the first question is related to the ethical considerations in managing PNB in elderly patients or those with significant comorbidities.
Pardon me?
What are the ethical considerations in managing postmenopausal bleeding in elderly patients or those with significant comorbidities?
See, whether morbidity, comorbidities are there, only then those are the patients who get malignancy. Like say obesity is there, patient is having compromised lung, or patient is having diabetes, or patient having heart disease. So if they are there also, it is very important for you to evaluate if the patient is having carcinoma endometrium. So probably patient may not be able to go for endometrial biopsy under GA. But even those cases, she may be doing simple biopsy under local and confirm that it is not a case of a malignancy. And if not a malignancy, you can treat her with any drugs. If it is malignancy, whether she is having comorbidities or not, we have to evaluate and treat it. And I refer it to higher center where tertiary care where all things can be taken care of. Even the patient is having a case of valvular disease in a tertiary center where all the specialists are all the departments are there, we can always adjust and treat it. When patients are pacemakers are also, when you call them at that time, they will adjust the pacemaker, we do the surgery. Only thing you should know that you should not use a cautery. And after surgery again, they'll adjust the pacemaker. And so only thing is, they should go to a higher center, say in government setup or a private setup. If they know that there is have comorbidities are there, better they go to higher center and get surgery done.
Thank you so much, ma'am. Thank you for answering that question. We'll move to the next question, and the next question is related to the emerging treatments. So what are the emerging treatments and are being researched for the management of PMB?
See, the research in this, that's what I'm telling. See, when we were say students or assistants, we used to think carcinoma endometrium, close your eyes, do a simple hysterectomy, that's end of it. Now, the type of carcinoma endometrium has totally changed. It is all based on immunohistochemistry. Immunohistochemistry, all cases, they now ask you, as soon as you say HP report comes, patient needs immunohistochemistry. So it's a clear cell carcinoma, it is a case of simple adenocarcinoma, adenocarcinoid is there. So depending upon that, the patient can go even for gene therapy. So the research is all on the type of carcinoma it is. The histopathology depends upon the immunohistochemistry and the management, whether she needs, of course, hysterectomy is the gold standard. That's there. Beyond that, whether the patient needs chemotherapy, we were under the impression and when we were in junior life that only carcinoma cervix needs radiation and chemotherapy. Chemotherapy also may not be useful for carcinoma cervix, but now the chemotherapy radiation is even for carcinoma cervix and carcinoma endometrium, because immunohistochemistry, that how the cells react to it, what is gene therapy is all totally changing. So lots and lots of research is going. So you have to follow up the case now, not simply, we feel bad. Sometimes patient goes for hysterectomy in smaller places. This specimen is not even sent for histopathology. Patient says, I had some problem, they did hysterectomy, never gave any this thing. They come back to the secondaries. So it is imperative, even if in a small place you are doing, there is no problem. You put in formula, you can send it to a nearby higher center where they can have a histopathology and immunohistochemistry. Definitely tell what type of treatment you can take. And I don't think the money is a limiting factor, because there are so many in government schemes, even the poor patients are getting all the treatment. The thing is, they should have a eye to get it done, and the doctor should take interest in the treatment done.
Thank you so much, ma'am. Thank you for answering that question. We'll move to the next question, and the next question is related to follow-up protocols. So, what are the follow-up protocols that you would recommend for patients treated for benign causes of PMB?
Benign causes, I told you, it could be a simple hyperplasia without atypia, or it could be a polyp. So if the patient is having histoscopy and we are taking out the polyp, yes, we reassure her. So she has to come for checkup at least once in 6 months for a scan. And if she had a pap smear, if we all know, once we repeat after 3 years, that also is negative. The next pap smear is after 5 years. We do it up to 65. Some may be extend up to 70. Beyond that, usually we don't ask for any pap smear. But we had recently some patients who were 74 years with carcinoma endometrium, no history of any this thing. They had pap smears before also. So no age and no patient is totally free of malignancy. They should go for regular, I think a regular checkup once in at least 2 to 3 years, a regular scan and a pap smear and a regular health checkup will definitely pick up patients who have that. And in case of carcinoma endometrium without atypia, this patient should come for checkup at least once in a year. Get a scan done. If you think the enamel thickness is increasing, probably a biopsy may be needed. And as I told you again, patient cannot come for follow-up. You think this patient is going to lose follow-up. And another thing, patient is having economically, she is not able to come again to hospital follow-up. I think doing a hysterectomy and sending it for histopathology and relieving her is better than to wait and watch, see whether she's going to develop cancer or not. So each case has to individualize. Yes, we all want to be conservative, but not at the cost. See, a patient who is coming from a remote village, she comes here, she has a pneumatoid hyperplasia with heavy bleeding, hemoglobin is say 4 grams. I can give blood, ask her to give her on hormones, ask her to come back after 1 year. You think she can afford? And another thing is, coming from such a wrong distance, even taking hormones and coming for regular follow-up is not possible. So in such cases, I think doing a hysterectomy in a patient who is 45, 50 or late menopause 55 is not wrong. But everybody wants to be conservative. But whether patient can afford it or patient can come for follow-up is thing which that every doctor should think of.
Thank you so much, ma'am. Thank you for answering that question. One last question before we conclude. And the question is related to the lifestyle modifications. So, what kind of lifestyle modifications or preventive measures do you suggest to patients who are at risk of PMB?
One thing, as I told you, menopause is associated with hormonal changes and patient puts on weight. So, and they may be hypothyroid. So, ask any obese patient, I'm just because of the age, because of my hypothyroid, I'm putting on weight. Yes, that is a thing that is expected, but you know you are going to you put on weight. So lifestyle modification is first thing is to retain your at least previous weight. Don't put on further weight. Next thing is local hygiene. It's very important because keeping yourself hygienically, local vaginal hygiene is very important. And of course, to have a single partner or not to have this thing is very important. And taking, we tell the patient take Gardasil or any cervical or cervical vaccine that's available. That is definitely useful for patients at least to avoid carcinoma vulva and carcinoma cervix. And keeping her heart, BP, and her diabetes under control definitely will decrease the chance of developing carcinoma endometrium. So, lifestyle modifications include weight management, diet management, high protein diet with low calorie diet, and local hygiene and vaccination. And even uh, this thing, flu vaccine around 60 is also very important because that will also prevent unnecessary complications when the patient develops influenza.
Thank you so much, ma'am. Thank you for your wonderful talk and for answering all the questions for our viewers and making them understand about the topic in such a better manner. And I would also like to thank all of our viewers for their ardent participation that they have shown by staying tuned with us throughout and for their patience listening. So thank you so much to all of them. And with this, I would like to conclude the session here for today, ma'am. Until next time with you.